Okay, we're just about at 2 minutes past, so I might crack the top off this thing. Welcome everyone to our event this afternoon. Our event on harm reduction, the link between Australia's new hepatitis strategies and the upcoming new national drug strategy. Before I would begin, I would like to acknowledge the Ngunnawal people who are the traditional custodians of the lands that I'm coming to you from here today in the ACT, and also pay my respects to elders past, present and emerging on all of the traditional lands that everyone else is coming from here today, because I know we have a very broad spread of people from across the country. So acknowledging the traditional custodians of the lands that you're all on today and paying our respects to their elders past, present and emerging. I'd also like to acknowledge the ongoing contribution that the Ngunnawal people make to the life of the city and the region that I live in, and the traditional custodians of all the other lands continue to make to their communities and to the work that our organisations do. I'd also like to acknowledge the partner organisations to today's event, because I'm here with all my friends today. We are joined by representatives of the Australian Injecting and Illicit Drug Users League, Hepatitis Australia, Peer-Based Harm Reduction WA, the Penington Institute, and the Queensland Network of Alcohol and Other Drug Agencies. So you've got a stellar cast of people who are going to talk to you here today. I'd also like to acknowledge that we have in our audience in particular people with lived and living experience of alcohol and other drug use, and I'd like to acknowledge the work that they do in our community and also acknowledge the people that we've lost over the years too. I'd like to just point out that while we have disabled the chat and we're going to ask you to put your questions into the Q&A section here, we have got in the chat a list of crisis and support contacts there for anyone who needs them. And there's a list of crisis and support contacts from a variety of organisations that will be helpful to people in a whole range of ways, not just today. We also have the link to AIVL's NSP directory, which shows you where all the needle and syringe programs are around the country. So there's some useful contact numbers and links in the chat there for anyone who needs them. But just letting you know that if you want to ask a question at any stage, we're going to ask you to put that in the Q&A section, not in the chat, just to make sure that everyone gets their questions attended to. But just in terms of housekeeping, we're going to have all the speakers first. You're welcome to put questions in the Q&A section at any time you want, but we will be taking all of those at the end so that we can make sure that we get to all our speakers today. So to begin with, I'd like to introduce Rebecca Lang, who is the chair of my board of directors here at AADC and also the CEO of QNADA, which is the Queensland Network of Alcohol and Other Drug Agencies. And Beck is going to open the event by talking about why harm reduction is currently the most undervalued pillar of Australia's national drug strategy. Thanks, Beck. Take it away.
Thanks, Mel, and hello, everybody. I pay my respects to the Turrbal and Yagara peoples whose lands I join you from today in Meanjin. And I acknowledge that often our alcohol and drug policies disproportionately impact Aboriginal and Torres Strait Islander communities. The conversation that we've been having as the national peak for a little while now is noticing that there's a whole range of policy opportunities that are presenting themselves right now with the new national drug strategy due to be delivered by the end of the year, a national inquiry into the health impacts of alcohol and other drugs, and a reform process for the Commonwealth's drug and alcohol program. Our national drug strategy has been founded on those three pillars of harm minimisation for the last 40 years: supply reduction, harm reduction, and demand reduction. And we have we've made some really great strides over the last 40 years in terms of expanding access to treatment services, understanding what types of treatment services work for people. We still don't have enough treatment services, but when I started at QNADA a while ago now, one of the things that I would often come across is bureaucrats or public servants who weren't sure whether treatment was worth investing in or whether treatment worked for people. And we've certainly won some of those conversations. I think now there's a broad acceptance in the community and amongst funders that providing treatment services is a good idea. You used to hear people talk about how many goes will people get at treatment before we just say that they can't be helped. And I don't hear that so much anymore, which is, I think, a really positive thing. In In contrast, though, I suppose the thing that we've started to really look at and talk about is that we haven't seen the same kind of process of acceptability and mainstreaming for harm reduction services as we've seen for treatment services. So, we have planning processes to grow our treatment services. We have, sure, unstable funding arrangements, but continuous funding arrangements. And I just would like to compare that to harm reduction. Despite our understanding that since the introduction of needle and syringe programs, the thousands of people who've been spared bloodborne virus transmission, the thousands of people who've had access to harm reduction advice through those needle and syringe programs that they can then trust and apply in their day-to-day lives, despite the research evidence that proves that those things work really well, despite our understanding and the importance and the value of peer-to-peer based support services, we still have a really hard time getting new harm reduction services up, or getting harm reduction considered to be as front and centre in those planning processes. And I guess the thing for me is, coming in from Queensland, is that the two things that we've really had to fight for over the last decade are the introduction of drug checking services. Now, drug checking services were eventually embraced by our last government, but they took a long time to get them over the line, and it wasn't an intentional decision to implement drug checking services. It was an incidental change to the Medicines and Poisons Act and the associated regulation that kind of created this grey area where we're like, oh, could that mean that drug checking services are now able to be legally delivered in Queensland? Tested that out. The answer was yes. Then government came on board with, even then, pilot funding, as though drug checking services haven't existed around the world for decades now, as though they haven't existed in Australia for at least the last 5 or 6 years, and as though we don't have good information about the fact that people who use drug checking services are really interested in talking with those services about their drug use, about the way it might interact with any medications that they're using, and the fact that 50% of those people had never spoken to a professional or a peer about their substance use before. So obviously our first 𝐀𝐼VL detections came through those drug checking services. We discovered the vagaries of our ketamine market through those drug checking services, and all of the additional kind of risks that might come from those different novel formulations. And yet we still think that at a policy level, that those services are somehow controversial. I mean, we've seen through the drug and alcohol reform process, the Commonwealth talk about harm reduction being a state responsibility primarily, I guess forgetting their leadership in the implementation of needle and syringe programs and bloodborne virus testing. We see state governments cling to outdated prohibitionist notions that providing space for harm reduction services in some way condones or encourages people to use drugs, as though there's a whole raft of people out there who would be doing drugs if only someone would tell them that it was okay to do so. These ideas are really divorced from, I guess, the way I think people work, and they focus really strongly on this outdated notion that we can deter people from using drugs, which then leads us into wasting enormous amounts of public resources trying to scare people out of using drugs. But what we end up doing is scaring parts of the population about people who use drugs by overstating the dangerousness of the group of people who use drugs. As though we don't have a library's worth of evidence about what works. I think the thing that we're landing on at the AADC at the moment is that maybe the opportunity in our next national drug strategy is to drop supply reduction and focus on harm reduction, and really centre harm reduction responses and harm reduction approaches at the national level. And we'd love to see some leadership from our federal government around corralling our states and territories into maintaining the progress that we're able to achieve, and really centering people who use drugs in those policy responses. We also have the opportunity through the national inquiry into the health impacts of alcohol and other drugs to demonstrate the value of harm reduction approaches again, and to ask that our future approaches, funding approaches apply just as much attention to harm reduction and growing harm reduction responses as we do to growing our treatment responses. Because we know that while not everybody who uses drugs will need a treatment service, we know that harm reduction services absolutely benefit everybody who uses drugs. And I might just leave it there now.
Beck, I think you really set the scene pretty well there for where our conversation's going today. And just building on what you've said, I think for people who haven't been around this for a while, we know from the work that the Drug Policy Modelling Program has done over the last few decades here in Australia, that in terms of the investment across the three pillars of the National Drug Strategy that Beck spoke about, which is namely demand reduction, harm reduction, and supply reduction, we know that supply reduction, which is your law enforcement and corrections, gets double the investment that demand reduction, which is your treatment pillar, gets. And we know that harm reduction and prevention get a lot less than that again. So we're really seeing this disparity, and just noting that there's also recently a parliamentary inquiry in the law enforcement space, and that one, even though it was looking at law enforcement interventions, one of the key recommendations, as well as one talking about the need for a new national governance strategy, which we'll get to later, was about the investment across the three pillars. And even those in the supply reduction area were saying we can't do this by ourselves, and we need there to be equity and investment across the three pillars of the National Drug Strategy. So I think that's really one of the things we wanted to tease out today. And in terms of the cost effectiveness of harm reduction in particular, we know that, as Beck has said, the evidence is in, and the ACT government commissioned a report in the last 12 months that indicated for every dollar spent on harm reduction programs delivered a $10 dividend back to the community. So these are clearly cost-effective programs, and over time we've seen how the interface between the National Drug Strategy and the National Bloodborne Virus Strategies has worked and how there is such a crossover in terms of interventions and priorities. And that's where Lucy's going to take it up for us here. So we note that it was actually World Hepatitis Day on Tuesday, which is what started our conversation around having this event for you today, to talk about the interface between the new hepatitis strategies, which were quite a long time coming, and the upcoming new national drug strategy that we're going to have, because the current national drug strategy is due to run out this year. So Lucy's going to talk us through the new national hepatitis strategies and the priority populations and settings. And I think that's going to illustrate for anyone who's not across the two where the crossover is and how important that interface is in terms of the harm reduction work we're going to showcase here today. Take it away, Lucy.
Thank you. Thanks, Mel. And, as Mel says, the goals of the viral hepatitis response nationally and the goals of the AOD sector are so deeply connected. So it's lovely to be on a panel with so many of my colleagues. And I would also like to start by just acknowledging the Ngunnawal people whose lands I live and work and raise my family on. I also want to just acknowledge the disproportionate burden that viral hep places on First Australians. 18% of hep C exists in Aboriginal and Torres Strait Islander communities. And so we know that there's also great optimism, because when we see things done through peer-led and culturally appropriate ways, we get really good outcomes. So thank you for having me. Very quickly, for those who don't know, Hepatitis Australia's been around, we're 30 next year. This is our members nationally, the community hepatitis organisations. We also represent the 300,000 people who live with viral hepatitis in Australia. This is just a quick kind of overview of what that population looks like at the moment. So there are almost 230,000 people in Australia living with Hep B, 63,000 people living with Hep C. And, Hep C very much associated with drug use and alcohol use too. Hep B, injecting drug use is certainly identified as a risk factor for Hep B as well. So we sort of think about both the predominant forms of viral hep when we have this conversation. So the overlap between viral hep and AOD policy is obviously significant, the populations we work with are the same populations you work with. So it's a point that I have made. I know Mel's made it. I'm sure Ellie and the AIVL team have made it to the CDC and the Australian Department of Health that, you know, when we look at the viral hep strategies, it's very similar populations as the national drug strategy. So it makes sense that we'd be having this conversation together. Hep C, as we know, is treatable, it's curable, it's a course of tablets for 10 or 12 weeks with a 95% cure rate. It's not interferon like in the bad old days, which was a really hard course of treatment for people. So just a reminder that, you know, if you're thinking about Hep C, get tested, get cured. But we know that sharing injecting equipment remains the primary route of Hep C transmission in Australia. Injecting drug use, as I've said, is also obviously a risk factor for Hep B transmission. But also right now, today, people who are acquiring Hep C are people who've already previously been cured and reinfected. So we still see a lot of reinfection of Hep C. We have to maintain that focus on harm reduction. People need access to clean injecting equipment. We know that's critical for Hep C elimination. We also know that Hep C in prisons is really, really prevalent. So 8% of people in custodial settings in Australia are living with hepatitis C. Data from New South Wales tells us that 42% of retreatment happens in custodial settings. So real focus on prisons is really, really needed here too. So I'll just look here. The new national strategies were launched earlier this year in Parliament House by the Assistant Health Minister, and we launched those alongside a number of our partners from the national response. You can see me there with John G, my colleague from AIVL. And, you know, we are working with the Australian CDC at the moment to develop implementation action plans for both those national strategies to make sure that the strategies turn into action on the ground and maintain the momentum that Australia's already built towards 2030 elimination. And, you know, I'd really encourage a similar approach for the new national drug strategy. It's great to have a strategy. It's better to have an implementation process around it. So the goal in those two national strategies remains clear, and that is the elimination of viral hepatitis as a public health threat by 2030. That goal is absolutely achievable for Hep C, provided we maintain that focus on prisons, that focus on people who use drugs. It's more difficult for Hep B, but it is still achievable for Hep B. So these are the 4th and 6th national Hep strategies. What's in the new ones that's different to what's in the old ones? One of the things that we're really interested in this is the new stronger focus on human rights. And there's more discussion of human rights in both strategies. The Hep C strategy talks about the Mandela rules, which state, as many of us know, that the healthcare somebody receives in prison should be equivalent to the healthcare that people receive in the general community. We would love to see people in prison getting access to clean injecting equipment. We know nobody in Australia does at the moment, but we maintain that call. The other thing that's useful that's new and useful in the new national strategies is this equity threshold. And what that states is that we cannot, as a nation, claim to have achieved elimination of viral hepatitis unless we've achieved it equitably for everyone, everywhere. So that includes incarcerated people, it includes people who use drugs, it includes migrants, it includes First Australians. And that equity threshold is in the national HEP strategies as a result of a lot of community advocacy from HepAUS, from AIVL, from the Scarlet Alliance, from lots of us in the community sector. It would be great to see that threshold repeated in the drug strategy. Similar to the National Drug Strategy, harm reduction is a guiding principle in the HEP strategies. And, I think it's particularly important at the moment when We see the rise of new populist political voices. We see communities expressing concern in the media about needle and syringe programs, often very unnecessarily. We can't take that for granted. We have to maintain that commitment to harm reduction processes. So I think it's great that it's in the HEP strategy. It's great if it's maintained in the new drug strategy. Priority populations are really clearly identified. So you can see across both the Hep B and the Hep C strategies, we are looking at those who need us most, sex workers, people incarcerated people who inject drugs. You can see that repeated across both the strategies. And the benefit of that, in addition to the equity threshold, is that it enables us to drive the activity to where it's most needed in the community and make sure that nobody gets left behind. The HEP strategies also talk about priority settings, and it's really great that there is a focus on community-based settings because it really reflects the place-based, person-centered response that's needed to both Hep B and Hep C, and that's obviously the way that many of us work, and that's really reflected in national policy, which is fantastic. And I will wrap up here, Mel, with a quick plug for HEP Australia's HEPLink telehealth service, free national telehealth service for anyone at risk of Hep C. Give us a ring. We can connect you through to a nurse practitioner who can sort out testing, and we've even got a mail-out treatment service, all bulk billed under Medicare. So that's it. Thank you.
Excellent. Thanks, Lucy. And for anyone who missed Lucy's last slide, you can go to the chat for the HEPLink contact details as well. And they are in there for you too, because that's a service that is really great and available to all. So contact details in the chat if you missed them from Lucy just then. And I think something that's really struck me, having worked across organisations that are involved with both the hepatitis strategies and the national drug strategy, is where we're moving in terms of prescribing. So in terms of hepatitis C treatment and care, nurse practitioners are very much in the frame in terms of enabling access. But there is a real opportunity there, I think, in particular for increasing access to pharmacotherapies in the alcohol and other drug space as well. That is an opportunity going forward. And I think when you see how those priority populations are intersecting, there are certainly lessons that can be learned and synergies that can be built on in terms of the implementation of the national hepatitis strategies and the development and implementation of the new national drug strategy moving forward. And in terms of talking about that interface between the two national strategies and what that looks like in terms of implementation and where the rubber meets the road, we have up next Ele Morrison, who is the Deputy CEO of AIVL, the Australian Injecting and Illicit Drug Users League, who's going to talk to us about how the harm reduction work of AIVL and its member organisations in each of the states and territories connects those priorities of the national hepatitis and national drug strategies, because AIVL and its member organisations really are straddling two worlds in terms of the national strategies and building those connections. So Ele, please take it away and give us a bit more of a explain for those who are in one sector or the other of how these things connect.
Thanks, Mel, and thanks for having me in this webinar today. It's a really important one to be talking about, I think. So I would also like to begin by acknowledging the traditional custodians of the lands on which we are all meeting. I'm joining from the lands of the Wurundjeri Woi-wurrung people of the Kulin Nation. I'm in Naarm in Melbourne, and I pay my respects to elders past and present. It always was and always will be Aboriginal lands. So today I'd like to talk about how the harm reduction work of AIVL and its member organisations, with the leadership of many people from my community who have worked on these strategies over many, many years, connects the priorities of the national hepatitis strategies and the national drug strategy. So people from my community to be clear, that's people who use drugs and particularly people who inject drugs. We are the community that has a stake in the National Viral Hepatitis Strategies and the National Drug Strategies. Those strategies are all about us. Throughout our 40-year history, AIVL and many of our member organisations at the state and the territory levels have been funded mostly through bloodborne virus responses and especially hepatitis C. More recently, some of our organisations have expanded more into alcohol and other drug work, but we've never actually been defined just by our funding streams. Like, nobody walks into one of our peer organisations because they've read a national hepatitis strategy and they see themselves in it. They come because they need sterile injecting equipment, they want access to opioid treatment, or they've experienced discrimination when they've tried to access a health service. So for us, we care about viral hepatitis prevention, testing and treatment, of course, but we also care about safer injecting and vein care. We care about peer support and we care about drug policy. So for us in our communities, all of these strategies really matter to us. So to do this talk, I want to talk about them in a little more depth and about a couple of things in particular that you see in all of these strategies. If you look at, or you compare the National Hepatitis B and the National Hepatitis C strategies with the drug strategy, you'll notice there are some pretty obvious differences. So as Lucy was saying, the viral hepatitis strategies that have recently been released demonstrate what's possible when we have like a broad group of people, including people with lived and living experience, genuinely involved in developing them. So they have really person-centered language. They talk about equity and human rights. They recognize peer leadership and they put stigma and discrimination as central barriers to health. The current national drug strategy, which was developed in the mid-2010s, is a very different document. So there's very little about peer leadership. There's very little about the peer workforce. And stigma really, like, it barely gets a mention. And I think those differences really matter because these strategies influence where governments invest and what services are funded and how communities are treated. So even though the drug strategy talks about a balanced approach across the 3 pillars of harm minimization, again, we've already heard that that balance doesn't exist in practice, that harm reduction receives around about 1.6% of the total budget for drugs in Australia. Even though it has the most evidence for it, it receives by far the least funding. Having said all that, I think that the hepatitis strategy could go further. So again, we've heard a little bit about the priority populations today and how they do have like quite an inclusive presentation, and there's real benefits to that. But it also, in some ways, presenting the priority populations like this makes them look very equal. We think that for hepatitis C in particular, the people who inject drugs are the priority population. So we spent a long time over the years trying to educate people about what blood-to-blood contact means. It's a complicated virus, but any person who's lived with Hep C can tell you that having your family label your cutlery so that no one else can use it, or worrying about your kids touching your toothbrush, like these things don't make you feel less stigmatized. So we need to be really careful when we talk about who the priority populations are, what the risks are in transmission. It doesn't diminish the importance of people who may have acquired Hep C in other ways. So for example, the prison issue, definitely tattooing in prison is a risk for people, and that's because we're not providing the resources in prisons that we should be. people who've acquired hepatitis C in any way obviously deserve testing and treatment. But we do need to put the resources where the evidence is, and that means centering people who inject drugs as the priority population. We can't eliminate Hep C by 2030 if we don't have prevention, testing and treatment accessible for people who inject drugs. And all of this, I think, comes back to stigma and discrimination. So stigma is not my favourite word. When we talk about stigma, what we're usually talking about is the hatred, frankly, and the discrimination that we experience as people who identify as injecting drugs. So I'm about to show some language that some people might be offended by, but I think it's important to show it. We normally don't leave it up, but this is the kind of thing that we get in our social media feeds all the time. So these examples came from us talking about the right of people who inject drugs to get Hep C testing and treatment. And they're not very nice, and we don't get to ignore them. And these kinds of attitudes are what we know a lot of people think about us. So they're the reason why going into a health service that has a secondary NSP or going for hepatitis B or C testing is incredibly hard for some people. So while most health services are not going to use this kind of language when you go into a service, we've still experienced discrimination in health services, many of us, and these kinds of messages are behind what we feel when we experience discrimination, when we experience stigma. They're the kind of attitudes that we're waiting to hear, basically. So you can't eliminate hepatitis when there's still discrimination as part of healthcare. And that's where AIVL and our member organisations come in. So providing services that are non-judgmental and having enabling environments around us, that's what we do every day. Because for us and our communities, eliminating hepatitis B and hepatitis C means doing all of the things that show that we're humans. We run needle and syringe programs and overdose response and drug checking services. We invest in harm reduction. We're advocating for better opioid treatment. We're calling out discrimination, and we're always advocating for drug law reform and human rights. And I can't overstate how important it is to have peers leading these services for our community. Like, all of these issues are important for us all of the time. So going back to the National Drug Strategy, we're in the process, as we've heard, of developing a new National Drug Strategy. And I think the way that the hepatitis strategies were developed with input from our community and genuine input from people with lived and living experience of hepatitis B and hepatitis C are the reason that the viral hepatitis strategies have that much more human rights focused language and ideas, and as compared especially to the outgoing drug strategy. I think the next drug strategy should learn from the hepatitis strategies. So I think that peer organisations need to be embedded in the development and implementation of the new drug strategy. People who use drugs should be seen as having dignity and human rights throughout the document. Stigma and discrimination should be recognised as the major public health issue that they are. And it should call for genuine, equitable investment in evidence-based harm reduction. So in closing, for the 3 or 4 decades that AIVL and our member organisations have demonstrated what happens when people who use drugs are trusted to lead the responses that affect our communities, I think the next National Drug Strategy has an opportunity to build on that legacy. The people most affected by these strategies, we're not just beneficiaries of policy, we're not criminals, we're not risks, we're not health issues, and we're definitely not just viruses. We're experts in what works, and if we want better hepatitis outcomes, and better strategies that guide our responses to drugs, we have to improve the drug laws, we have to resource the peer workforce, and we have to place the expertise of people who are affected by the strategies at the centre of them. Thank you.
Thanks, Ellie. That was an incredibly important presentation, and I think, you know, it's really important to really flag the stigma and discrimination that also intersects across these strategies that we're talking about. I mean, I know everyone will be shocked and horrified that you said that people on the street don't read the national strategies. I'm shocked to learn that myself. People have these things next to their beds at night and on their coffee tables, surely. But thank you for bringing alive for us how those strategies intersect and how the issues that are impacting people on a daily basis intersect in this way, and how that affects what we see in terms of the interventions that we're trying to get support for here. I think the other important point that you raised as well is around national governance. And we know that the law enforcement, the recent federal law enforcement inquiry, and as well as the evaluation of the Commonwealth's drug and alcohol program that provides funding to drug and alcohol services around the country, a whole heap of those recent reports have advocated for the re-establishment of a robust national governance framework for the alcohol and other drug sector. And in the bloodborne virus and sexually transmissible infection sector, we have national governance frameworks that include things like the Bloodborne Viruses and Sexually Transmissible Infections Standing Committee. I had to actually read that acronym because I always just say Beavis, and yeah, I had to actually read out what that meant. It's a mouthful. But the members of that include representatives from the state and territory governments, the Commonwealth government, but also community sector representatives, importantly. So ASHM, the Australasian Society for HIV, Viral Hepatitis and Sexual Health Medicine, the Australian Indigenous Doctors Association, AIVL, Hepatitis Australia, the National Association of People with HIV Australia, the Scarlet Alliance, the Australian Sex Workers Association, Health Equity Matters, and NACCHO. So what we've seen recently is the re-establishment of a time-limited working group for the National Drug Strategy, and includes some government representatives from the Commonwealth and the states and territories, but we really haven't, it doesn't have any community representation on that. And we know that, as Ellie pointed out, in developing and implementing these strategies, community are central to the response in terms of not just what's included in the strategies, but what the implementation means and looks like on the ground. So really, that's another space in which the response to viral hepatitis and bloodborne viruses and sexually transmissible infections more broadly under those national strategies is really ahead of where we are in terms of the national drug strategy, because of the inclusion of key groups and the ability of national governance structures to really work together on the development and implementation of those strategies. So more lessons that can be learnt in terms of the development of the new national drug strategy and the structures that support it. So thank you for that. We're going to go back to and revisit in a couple of presentations' time, you know, some more where the rubber meets the road in terms of harm reduction services and peer-based drug user organisations and their role at a sort of case study level. But before we do that, I'd like to introduce another one of my very impressive colleagues in the sector who I've known for a very long time now, although we're both way too young for that to be a true statement. John Ryan is the CEO of the Penington Institute, and John's going to talk to us and give us the benefit of his wisdom across, you know, the years of experience he's had, but also provide an overview of Penington's annual Overdose snapshot and the policy implications of that from a harm reduction perspective. So I'm not going to steal John's thunder, but the latest Overdose snapshot has some pretty bloody shocking statistics in it, and goes to the need for a greater investment in harm reduction initiatives and greater equity in the investment across the national drug strategy pillars. So that's harm reduction, demand reduction, and supply reduction, and the importance of that investment being equitable. And sadly, what happens when for the last 20 years that investment has not been equitable. So, John, can you take it away for us and tell us about that annual snapshot report and what's in it, and what you think the policy implications are in the context we're talking about today?
Thanks, Mel. Thanks very much for the invitation to speak and to speak actually about the overdose snapshot. I've not realised until today the sort of impact that the BBV sector had in relation to the overdose report. I started work in this space in needle and syringe program harm reduction sort of work, and I can remember, and it's only listening to the previous excellent presentations, it reminded me of something that happened sort of 15, 20 years ago, which was that there was a slight uptick in the number of HIV positive diagnoses in Victoria. It wasn't, like every life counts, but it wasn't a tsunami, but it resulted in a tsunami of government action, which was, I think, appropriate. It was a ministerially appointed HIV task force, and the urgent priority was to address the increase in HIV diagnoses. I think that says something about the communicable diseases space and obviously the hepatitis space. We've heard about the connections in terms of the importance of community, also the importance of proper governance systems, and it's the data bit that's been really impressive as well, I think, in relation to communicable diseases, and that idea that you've got to actually follow where the evidence leads you to, and the importance, in fact, the centrality of evidence in the response to BBVs, I think, has been a foundational part of Australia's successful approach, especially in relation to HIV and in relation to miracle cures for hepatitis C. That's not the experience that I've observed in the drug space, and I think that sort of old cliche, if you don't count it, it doesn't exist, is actually what sort of drove, I realised today what really drove the invention of the Overdose report by Penington Institute, because we were hearing lots of stories from people on the, people directly affected by drugs, people working on frontline services about overdoses, but it wasn't actually being counted, and it was more of a whispered issue back to the HIV/AIDS days, where people would die from pneumonia rather than AIDS-related illnesses. People were dying from overdose, but it was being, it was a heart attack or it was suicide. It was anything but an overdose. And so we really wanted to start counting it. 10 years in, we're still counting it. It's not a funded activity from the Australian government, unfortunately, but we still do it because it's such it's a crisis, actually, in my view, in Australia, which is not getting the attention that it deserves. When we started the overdose report, the road toll was only a little bit less than the number of annual deaths from overdose. Fast forward to the most recent report, overdose deaths are double the road toll. And so we've seen basically a deterioration. This year's overdose snapshot was the worst numbers this century. And, this is a morbid topic, but it's a reality that I don't think we're actually facing. There were 2,596 people that lost their life in the most recently recorded year. Those numbers will actually go up as the data is finalised. 2,091 of them were unintentional overdoses. In other words, they're very preventable deaths. And the sad thing to my mind is, losing someone in Australia every 3.5 hours doesn't create a national task force. It creates, a curiosity, and it certainly doesn't shake government out of a complacency in terms of harm reduction funding that we've heard about today. And it's not like it's just all one type of drugs or one type of people or one type of area of the country. It really is spread right across the country, and it's spread right across drug types. So opioids are still making a major contribution. It's the biggest year for heroin deaths this century, but also pharmaceutical opioids are making a big contribution. Stimulant related overdoses are up. Cocaine related overdoses are up. Benzodiazepine is still a major contributor to overdose, no longer the second but the third most commonly detected drug in an overdose. And across the geographic spread of the country, it's really, I think, extraordinarily bad news. Why is it that the 33% increase in overdose deaths in Queensland doesn't create a state of emergency? Why is it that the increase in South Australia, 49% in a year, doesn't create a state of emergency? I think it's an extraordinary failure of our imagination as a country that we can't actually face up to this problem. And it's a problem, it's across the age range. The most common decade now is people between 50 and 59, but there's been a very significant increase in people between 30 and 39. So really, how is it possible that something that is such a stark contrast to the road toll doesn't generate the attention that it deserves? And I think we pretty much know why. It's that some lives are valued more than others, and unfortunately, because of the shame and the silence and the secrecy around these issues, we don't get the sort of robust response that is required. And if I think about the way that we innovated in relation to the HIV epidemic, there were some extraordinary things that happened in those days, which really made us a world leader. We haven't done the same thing when it comes to actually facing up to drug problems. And, some things are easier than others. We obviously still have major lack of access to opioid replacement therapy in Australia. There's not enough prescribers willing to participate in the most gold standard evidence-based drug treatment for opioid dependence. There's still not enough people that know about the signs of overdose, let alone how to respond to an overdose, let alone be well prepared and have naloxone at hand. So they're really simple things to my mind. We've heard about the drug and alcohol program not including a robust approach to harm reduction. And so we've got the continuation of, I guess, an old approach to drug policy, which is a reliance on drug treatment, supply, and 2/3 going to supply control. We're still neglecting the harm reduction element. And from a governance perspective, to my mind, that's where an overdose strategy would actually make more sense. We need some accountability in relation to the overdose toll at a jurisdictional level, but we also need accountability at the national level. And I really like that learning that we've had from the BBV sector, but we've also got learning from the old governance structures that we had in the drug and alcohol sector that survived into the Howard years, from the Labor years into the Howard years, which was a Ministerial Council on Drug Strategy that had leaders from all jurisdictions, from the health silo and the law enforcement silo. Because I think without that kind of cooperation and concerted activity, action and accountability, the accountability of an overdose strategy with clear targets and public annual reporting, I don't think we've got the momentum to really address what is now tens and tens of thousands of people unnecessarily lost to drug harm, aka overdose. And really, in the end, I think we've got to start treating drugs according to their harm profile. And that's part of the reason why Penington Institute really pushed and continues to push for the regulation and access, regulated adult access to cannabis. Why is it that we are still leaving people at the mercy of the illicit drug market when we know that cannabis is a much less harmful drug, and we could be reducing exposure of young people to supermarkets that are available via drug dealers? We could actually take a whole lot of business away and regulate it and tax it, but we're not doing that. It's a pretty logical thing. Why wouldn't we be treating drugs according to their harm profile, and why wouldn't we be focused on evidence and innovation as Australians in relation to the overdose toll? it's a question that I think our political leaders need to ask themselves. Thanks.
Thanks, John. That was a pretty hard-hitting presentation, I've got to say. So some key messages from that. We know that we're now at a state in time where overdose deaths are double the numbers of road accident deaths in Australia. And we've got from being about the same as road deaths to being double road deaths at the same time as we have a disparity, an ongoing disparity for the last 20 years in the resourcing that is provided under the National Drug Strategy across the 3 pillars. So we've talked about that before, but in terms of numbers, we know that 2/3 of the people who need to go to drug treatment miss out because there aren't the places for them. We know that 500,000 people in Australia miss out on drug treatment, alcohol and other drug treatment each and every year because of a lack of capacity in the system. And we know that proportionally harm reduction services get even less resourcing than that. So is it any surprise that in that context we've had the rates of overdose now being double the national road toll? In the same time period, we've seen, as John said, the national governance frameworks for the National Drug Strategy removed. We used to have, as John said, the Ministerial Council on Drug Strategy that then turned into the Ministerial Drug and Alcohol Forum before it was completely abolished. We used to have an Intergovernmental Committee on Drugs, which has partially been rebirthed happily. So we're moving in the right direction again, hopefully, in terms of the re-establishment of the new National Drug Strategy Working Group. However, at this stage, that's a time-limited working group and it was only due to meet twice a year. So hopefully that will be built on going forward. But I think we also need to acknowledge, in terms of the harms that Lucy spoke about as well, that there used to be a National Indigenous Drug and Alcohol Committee that was responsible for the development and implementation of the Complementary Action Plan for Aboriginal and Torres Strait Islander people under the National Drug Strategy. That sub-strategy finished in 2019, and in the absence of a National Indigenous Drug and Alcohol Committee, we don't even have one anymore. It just lapsed and it's never been replaced. In talking about the new National Drug Strategy and appropriate sub-strategies, John also highlighted that we should really be talking about a sub-strategy focused on overdose under the new National Drug Strategy. And if some of our organisations had a seat at the table at this new National Drug Strategy Working Group, perhaps that's one of the things that we might be raising in the context of the development of the new National Drug Strategy as well. But I'll stop monologuing and throw to our last presentation, which is going to lift our mood a little bit ahead of the panel presentation, I think, because we have our colleague Paul Dessauer from Peer-Based Harm Reduction WA coming along to talk about what the work of his organisation is. So Peer-Based Harm Reduction WA, this is a case study of the scope of harm reduction work undertaken by peer-based drug user organisations, and in particular the work that is being done in WA. And this really builds on what Ellie was talking about before in terms of providing a case study of how the work of peer-based drug user organisations really brings together those priorities around the National BBV and STI strategies and the National Drug Strategy. So take it away, Paul.
Thanks, Mel. Good day, everybody. My name's Paul. I just want to acknowledge that I'm joining you from Boorloo here on unceded 𝐸𝐺 𝐸𝐿𝐺, and I want to pay my proper respects to Noongar people, to their history and culture, their elders past and present, and I'd like to extend that acknowledgement and that respect to all First Nations people. So I am the CEO of Peer-Based Harm Reduction WA. We were founded in 1996 by people who use drugs, and we've grown to be the largest single provider of health and harm reduction services for people who use drugs in this state. We're community-led. We employ people with relevant lived and living experience at every level of the organisation, from our volunteer base up to our committee of management. And I've been working for this mob for 26 years now. And I'm quite proud to be part of a team that has a reputation for developing innovative harm reduction interventions. And we develop them in response to emerging trends or to gaps in services that are identified by our consumers. And we do it in a process of co-design. So I've been asked to talk about the scope of health and harm reduction work provided by peer workers. And so I need to start by acknowledging there are drug user organisations in every state and territory, and they're all funded to do different things, and they all provide different mixes of services. And obviously I'm going to be speaking about what I know best, which is my mob. So a quick overview. Peer-based harm reduction WA provides more than 30,000 occasions of service every year, largely to people who are currently injecting drugs. About 24% of the people we see every year are Aboriginal. About a quarter of the people that we provide services to are homeless or street present. All of our services are low threshold, confidential walk-in services. There's no waiting periods, there's no appointments, there's no exclusion criteria. We never ban anyone from any of our services. And we use mobile and outreach models to go to where people are. You may be aware that WA is kind of big. It takes up a third of this continent. And you may be less aware of what a sprawl Perth is, even if you live in the capital city. The greater metro area of Perth is actually the widest city on the planet. There's only about 3 million people here, but it covers a larger geographic footprint because we don't like building up, we build outwards. And that has all sorts of implications for service delivery. And if people, a lot of the more newly developed outer suburbs have very poor infrastructure and services, but they have a large amount of public housing. And if you live out there and you don't have a car or you can't afford to put petrol in the car, it's very difficult to access centralised services. So what do? Our bread and butter is needle and syringe distribution. We're the largest provider of needles and syringes in the state. At the moment, we provide about 3 million pieces of injection equipment a year. It's about 35% of distribution throughout the whole state. And we do that from fixed site needle exchanges in Perth and in Bunbury, which is one of the major regional centres in the southwest of WA. We also have mobile vans that work through that whole southwest region and outreach to people's homes. And that network through the metro area and the southwest region gives us privileged access to populations that mainstream health services tend to describe as difficult to reach. And one of the things I'd like to encourage you to do is think about language you use and not using deficit-based language. When a service says that a population is difficult to reach, what they're really saying is that their service model contains systemic barriers that make it difficult for some people to access that service. Yeah. So about a quarter of our delivery is actually provided by outreach. So last year in Western Australia, there were 8.5 million syringes distributed by all of the needle and syringe programs in the state. And 8.4% of those 8 million syringes were provided by one guy named 𝐸𝐧, who works for us 4 days a week. And that's that. I can't tell you how that much it blows my mind that one 0.8 FTE worker is providing nearly 8.5% of the needle and syringe in the state. He basically drives around all those outer metro areas I was talking about in Perth. So our Perth site's open every day of the year apart from public holidays, and it averages between 70 and 80 people a day. And all of the other services that we deliver kind of piggyback off the privileged access that huge network of needle and syringe distribution gives us. So John mentioned overdose strategy and our responses to overdose. We have a very high level of drug-related deaths in WA, and we have since the late 1990s. I started working for this mob in 2000. We actually had an informal take-home naloxone program then, where we found some GPs who were happy to prescribe to people at risk of witnessing an overdose. This is a booklet that we produced back then with the old mini-jet device, which is no longer in use in Australia on it. We piloted take-home naloxone, a peer naloxone pilot in 2013, and we've We've developed the model that we use to deliver that over the years in consultation with the Drug and Alcohol Office and later the Mental Health Commission of Medicines and Poisons. We're the largest provider and distributor of take-home naloxone and brief education about recognising and responding to overdose in WA. We provide about 200 naloxone kits a month, just under 2,500 a year. We know that somewhere around 65% of the people getting kits off us are getting them to replace kits that have been used to reverse an overdose. So we're not just distributing a lot of naloxone, we know it's going to people who are frequently witnessing and responding to overdoses in the community. In the last couple of years, we've been able to get volunteer peer educators authorised under Medicines and Poisons to provide naloxone. At the moment, we have a team of 6 volunteer peer educators who check in with us regularly, and they provide about a quarter of those 2,500 kits we provide every year, just 6 volunteers. And they're getting to people who aren't able to access take-home naloxone through other services. They're distributing it through their social networks. So that's an example of some of our peer education programs. We have a model we developed in the mid-2000s where if we want to do something with a particular population group, we have a target group, we recruit people from that group who have big social networks, and we train them up, and then we support them to act as peer educators within their community. And we've done this with stuff around amphetamine use. We've done it with people responding to opioid overdose. We've done it with communities from culturally and linguistically diverse backgrounds. We've done it with Hep C peer educators who would incentivise people to come in and get tested. At the moment, we're running a project funded by Burnett called Deadly Peer Mob, where we have a Noongar project officer who's recruited a bunch of peer educators who are referring people into our clinic for us. It's about going to where people are and meeting them where they're at, instead of expecting them to prioritise what we want them to be doing and expecting them to seek us out and make an appointment to come there on time, yeah? So I do want to challenge this idea that harm reduction is somehow a state responsibility. For more than a decade, I led a federally funded team of 5 peer outreach workers, and that was funded under the old NZOTP grants, which were part of the drug and alcohol program until about, I think, 2016 is when all that money got sent to primary health networks. We had another project under that ran for even longer, and it was called the Drug Treatment Referral Service, which meant that we had a counsellor on hand at all times because people present with multiple problems in multiple domains in their life. And Ali mentioned that, you know, funding is siloed, but people's needs are not siloed, yeah? So we're currently about to get a new contract with the Mental Health Commission here for a peer counsellor. It's going to be called the Harm Reduction Treatment and Referral Service. And we're really looking forward to having that because it'll allow us to provide more whole-of-person services to our consumers. I want to describe as an example of how we work our health team. So we have a nurse practitioner-led multidisciplinary team, and the model of care we employ was developed by consulting our consumers, holding focus groups, asking them about whether they've been tested or not, asking them about if they'd tested positive, whether they'd sought treatment or not, asking them about why, asking them about why they thought their friends did or didn't do those things. And there were some pretty clear themes that emerged. And then we basically iteratively designed our model of care based on the enablers and the barriers that those community members identified for us. So the nurse practitioner-led team has an RN or an EN working underneath the nurse practitioner, but they're embedded within the peer-based service. It's kind of upside down to how mainstream health services are doing this. So there's lots of clinical services that are now trying to bring lived experience workers on board. We do it the other way around. The clinical team are part of the peer team. And we have low-threshold walk-in clinics, which are co-located in our fixed-site needle exchanges. You don't need an appointment. You just walk in on a day when the nurse is there. We have mobile health clinic vans that go to homeless drop-in centres, supported accommodation providers, community open spaces. At the moment, we're delivering clinics in partnership with 𝐸𝐿 Aboriginal Corporation, which is the Noongar drug treatment agency in the Perth area. And those clinics provide testing and treatment for Hep C, but they also provide testing and treatment for other BBVs and STIs. They provide wound care, vaccinations, sexual and reproductive health, contraceptive advice, Implanon. We have point of care, GenExpert instruments for Hep C. We were an early adopter of that technology. We have point of care testing for syphilis. We have portable FibroScan machines and ultrasound devices, and all of this diagnostic tech can be put in the vans and taken out to the community to where people are. So the important thing about this model is our peer case management workers. We have 2 peer case management workers, one in the southwest, one in Perth. They're trained to perform venipuncture. They're trained to be GenExpert operators. They're trained to do pre and post-test counselling. They're trained to conduct FibroScans. They're trained to do the data entry into REDCap. So our model has devolved a lot of things that would normally be done by a nurse or a doctor to the peer workers. It's a lot more cost effective, and it basically means we can send one nurse somewhere with a peer worker and we're testing twice as many people. Yeah. Those case management workers are outreach workers as well. So they can, once we've engaged someone in treatment, they provide phone support, they can transport people to and from appointments if necessary, they can deliver medication to people's houses. We never give someone a prescription. We always hand the medication to them, yeah, because it's just one other place where the chain might be broken if you're expecting them to go and fill a script themselves. And Ele has also highlighted just how poorly our community are treated in mainstream health settings. I personally think as a sector we should try and avoid using the word stigma. I prefer to use the word prejudice. You know, I prefer to call it what it really is. And, you know, when we use the word stigma, it's this airy-fairy thing that happens that if we only educated people, maybe they'd be nice to people who use drugs. When we say prejudice, we're actually locating the problem where it is. Yeah? It's inside the person who expresses stigmatising attitudes. It's not inside the person who's subjected to that prejudice and discrimination. And this stuff has real impacts on our consumers. I'm going to need to finish up in a sec, so we have time for a panel, but I just want to quote a couple of my colleagues. So our current health team lead, Julie Byrne-King's very experienced emergency department nurse who's been working on our team for several years as well. And she talks about relocating the clinician, about decentering authority. And she talks about the contrast between the way that we work and the way most mainstream services work, where there's a hierarchy from the senior clinician down to the nurse practitioner, down to the nurses, and then the peer workers are usually there to kind of provide moral support. You know, so I'll hold your hand while the professionals do things to you, yeah? And by flipping that model upside down and by empowering the peer workers to do some of the clinical work, it's not just a better experience for our consumers, it's far more effective. And the other person I want to quote is my colleague Peter Garver. There's an article that was just published in Contemporary Drug Problems, but it's actually based on the plenary session of the 15th Australasian Viral Hep Conference in 2025. And that article has quoted presentations from some absolute rock stars of the harm reduction movement in Australia, like Sione Crawford and Kate Sear and Charles Henderson, Alana Jeffries, Amanda Enderman, and my colleague Peter Garver. And in her part of that article, she talks about how the elimination of Hep C by 2030 is not actually a goal for an individual who has Hep C, it's a goal for the health sector. And we shouldn't expect people who have all sorts of other shit going on in their lives to be prioritising our national health goal. As I think, was it Mel who said, you know, people, oh no, it might have been Ellie said people don't make decisions because they read the national strategy, yeah? So she talks about this phrase I really love. She talks about how do we welcome people back to healthcare? You know, people who have been alienated, marginalised, discriminated against, deterred, actively deterred from seeking help, how do we welcome them back into healthcare? And it starts with consent, and it also starts with treating people with respect, and it starts with listening to the problems they identify in their lives. And when we do that, when people have a positive experience in a healthcare setting, then they come back again, and they come back again. And they might not be doing everything we'd like them to do the first time we meet them, but the first step is to secure that engagement. And I would suggest that has application much more broadly than just the work that my teams are doing. Thanks, folks.
Thanks, Paul. I think that's a perfect introduction to our panel discussion and lead in there as well. And I think, you know, the point that you're making, Paul, is well made, and I think it's really important that we have this conversation in terms of the context of the development of the new national drug strategy, and now that we're looking at this reform of the drug and alcohol program, which funds alcohol and other drug treatment services and harm reduction services around Australia from the Commonwealth at this point. And I think what Paul and Ellie have done is really illustrate where those shades of grey are in terms of harm reduction and treatment, and as well between the national strategies. And I just want to point out, in terms of the approach that Paul has illustrated today, this document, I'm going to try and see if I can make it show up here. Here we go. Can I make this happen? No, I'm not going to be able to make it happen because I got this weird background. I'm trying to show you 𝐸MA's peer treatment support service model of care. So the Canberra Alliance for Harm Minimisation and Advocacy published this document that was launched by the then Health Minister, who's now the Deputy Chief Minister here, last year. And it outlines the work that they're doing in the ACT around exactly the kind of model that Paul is talking about, in terms of meeting people where they're at and providing not just multidisciplinary, but multi-sector care. So people are presenting with whatever their life problem is. And if 𝐸MA can't help them with it themselves, they will provide a warm referral to whatever service they need, whether that be child protection interventions, whether it be criminal justice assistance, whether it be alcohol and other drug treatment, whether it be housing services. But it really goes to illustrate that intersection between national strategies, and not just the three that we're talking about today, but how those whole of government responses really come alive. Because we are talking, if anyone does read these documents, like the nerd that I am, all of these documents are now talking about whole of government responses and person-centred care. And I think some of the examples we've talked about today really show what that means, where the rubber meets the road. So let's go to our panel. Now, while we do that, I just want to point out to everyone the Q&A section again. Some people have started to put some questions in there, which is awesome. Thank you. You'll note when you go in there, there's a little thumbs up thing. That's where you can upvote the questions. So if someone's put in a question or comment that resonates with you and you want that one answered, you can just chuck a thumbs up on there and that'll push it up to the top, so that when we go to questions, we answer the ones that resonate with most people first. So you can put your questions in anonymously, or you can put your name up there, or you can just upvote ones that are already in there if they're reflecting what you're wanting to say. So start thinking about that while we first ask the panelists to respond to what they've heard today, because I think we've covered a lot of ground. Not everyone on this panel have met each other before. And I'd like to first, before we throw to questions, ask you guys who have given your perspectives today, what was something that you learned from the other speakers today that you would like to highlight, and how's that built your understanding, given what you came here to talk about here today? I'm going to go in the order of speakers to start with. So Beck, we haven't heard from you for a while. Sorry, mate, I am going to call on you first. Beck, what have you learnt today?
I think it's more about what I've been reminded of. It's always the thing that I always think about in these conversations is how easy it is to slip into that deficit-based language without even meaning to, because you kind of marinate in it because it's so common across the sector, and how you can never go wrong by remembering the people and just speaking about remembering you're a person as well in this conversation, and thinking about some of the wild kind of approaches that we have. I have been known to ask people if they've met anyone before, if that's how they think people work, because people who use drugs are not, like, I don't know, unknowable. Like, sometimes I think that the way we structure this is that it's not possible to understand the person who uses drugs, except for the fact that a lot of us are people who use drugs, and a lot more of us know people who use drugs. So the problem is our curiosity about that, not whether or not that's knowable. That's the thing I keep being reminded of.
Nice. I think that's a good reflection. Lucy, I'm going to throw to you, and I note that there are a number of questions in the chat that I'm going to throw to you later. So I'm just going to flag those with you so you can have a look after you've given your comment while I go through everyone else. Lucy, what have you taken away? You're someone who has come into the hepatitis sector from other environments. You're not a drug and alcohol sector person. What would you take away from what you've heard today?
First thing, I almost fell off my chair when John said the overdose rate is double the road toll. I mean, that's astonishing, really, when you think about the level of response, government response to overdose. And it kind of highlights the prejudice, because yay for moving on from the word stigma, thanks, Paul, the prejudice that people who use drugs experience when that the value of the response is not meeting the prevalence that we're seeing. That was astonishing. The other thing, Paul said something, and I want to get it made into a t-shirt, which says, welcome people back into healthcare. How great is that? What a good way to express that for people who have had such difficult experiences of the health system. How do we welcome people back into healthcare in a way that's safe and meaningful? It's hard in community work to measure impact sometimes. We're often asked to measure our impact the same way a big tertiary hospital is asked to measure impact. But if someone's coming into one of our members' NSPs and that person has a conversation about harm reduction and gets a bag of clean clothes and some food, that's a great intervention, even if they didn't end up with a Hep C test, or even if it takes us 2 years of those interventions to make them feel safe enough for a Hep C test. So, yeah, welcome people back into healthcare.
Thanks, Lucy. Those are, important points. It's a good conversation. Ellie, mate, what did you get?
I think for me, I was reminded again, like, how baffling it is that we aren't doing better, like how important so many things are, like the number of people that die, and it's not rocket science, like it's just treating people as people usually, and doing a bit of investment and whatever. I'm always shocked at how hard it is for us to do this when we kind of do know what is needed, I think.
That's the truth. John, you've been around both of these sectors for some time now. What are your key learnings from what we've talked about so far today?
I think that sounds terrible.
The fact that I have seen you around these traps for a while probably says something about both of us, I reckon. But yes, sorry, I digress.
I must admit, actually, it's partly the length of time that I've been in this space that makes me reflect positively on the part of the conversation today, because I think harm reduction was actually very difficult for the drug treatment sector, especially 25 years ago. There was a lot of resistance to harm reduction. There was even resistance to opioid substitution treatment. And I think the drug treatment sector has really changed not 100%, but it massively shifted in relation to those issues, which I think is a really, there's positive change that you don't notice it because it's sort of so incremental. But if you look back 25 years ago to now, I think that's a massive shift. And even AADC worrying about harm reduction is a great milestone, I think.
Now, that's an important reflection, isn't it? Like, we have really kind of got the band together here with the groups that we've got represented today. So hopefully in doing that, we can try and shift some of these problems that we've all been dealing with for quite some time. Paul, what do you got?
If I'm going to pick one thing from everything we've heard, it'd be John talking about the overdose toll and why is there not national attention on this? Why is there not a national campaign? If we have national campaigns around road safety, we have a national plan to end violence against women and children, although how effective that plan is might be a matter for debate. But we lose so many people to drug-related deaths, and the stigma and shame that families feel around this is horrific. It's a really horrible thing to be around, and we could do so much better. And if it wasn't for the prejudice around drug use, people would do better. Yeah.
I think that's important, and I'm just going to point everyone back to the chat because we've talked about some pretty hard stuff today. And if anyone needs some support coming out of today's discussion, there's some contact points there for crisis and support services where you can talk over some of these issues. I think Paul makes a very good point, particularly around prejudice as well. And I think that everyone who's been with us here today is going to think about that in terms of how they frame their language. And in terms of families, and not just families, but people working in the sector, that prejudice is real too. And I think that's a terrible shame and something that we all need to think about going forward. But I'm going to throw to the Q&A section because we've got some questions coming in thick and fast here. Some of them are quite detailed and some of them are more commentary. So let me try and crack a few of these out. I'm going to refer them to particular speakers here. But if you feel that there's someone else on the panel who you'd like to phone a friend on in any of these questions, or you'd like to throw it to someone else, please feel free to do so. And please feel free to jump in if someone who I'm not throwing the question to would like to have a go as well. So Lucy, as I flagged a minute ago, I think this first one's for you. Can I ask what opportunities exist for youth services to embed hepatitis awareness into broader health and wellbeing conversations with families rather than approaching it as a standalone issue due to existing barriers? I think that's something that Hepatitis Australia and its members have been doing some work on, isn't it?
Yeah, it is. And great question. And I'm also just looking at Carl's question a few rows down. Because when we look at new notifications in Hep C, about 7% of them are young men 20 to 25. And I think there's sometimes a kind of tendency to view Hep C as a historically acquired condition, or it's almost over, so don't worry too much about it. But we have to change the language for young people because we're just seeing new cases, particularly in young men. But also in young women. So I think the question about putting a spotlight on younger people is really, really important. In terms of how do we integrate that conversation more, we are trying to get more testing and treatment happening in inpatient settings, particularly inpatient mental health. We'd love to see more of it in AOD. Some AODs do it really, really well. Others need more help, which community HEP orgs can definitely offer, just to offer that intake or reception testing and get people connected to treatment as well. And certainly our telehealth service for Hep C is an opportunity there, but also community HEP orgs themselves, like AIVL, have peer workers who can be deployed to do some of that support activity too.
Excellent, thank you. Beck, just flagging, I'm going to point a couple of these at you now.
Well, just to build on what Lucy said, I think it's really important to remember sometimes that when we don't focus on young people coming through, what potentially we miss is those basics about harm reduction. Certainly here in Queensland with the rise in methamphetamine use, particularly in the far north, youth services up there are coming across young people who are being brought into injecting drug use behaviour by other young people who've never had contact with needle and syringe programs or good harm reduction advice. And so they're not necessarily learning or understanding straight away the importance of using sterile equipment, of not sharing equipment. And I think sometimes when we catch that later down the track, we just tend to see it as an issue of treating that one young person. But actually, I think it reminds us that these things are generational, and that while we do really good work to try and eliminate hepatitis C and HIV, we also have to keep in focus that that's about keeping the population understanding what some of those great strategies for reducing the prevalence of those viruses are, and doing the things that we know work. So, there's definitely a need to focus on young people, particularly here in Queensland.
Okay, that's made me go on a different slightly different tangent here, so I'm going to put a pin in the other question that I'm going to ask you, and ask Ellie and Paul to just comment on what you've said there as well from their perspective in working in peer-based harm reduction organisations.
Yeah, well, I'm happy to start. I 100% agree with what Beck has said. We've talked for a long time now about the aging population of people who inject drugs, and especially around opiate injection, and we're seeing actually that young people are taking up injecting opiates and methamphetamine and other drugs as well. And it has been traditionally not something that's easy for youth services always to talk about. And I think peer education in that space is equally important, that getting young people to understand safer injecting as early as possible will make such a difference to their health and well-being over time.
Yeah, so I guess one of the conversations I've been having a lot in the last couple of years with people across Australia is around how we sustain Hep C related work after 2030 or after elimination targets are reached, because elimination targets do not mean eradication. They mean that 90% of the population at risk have been tested, and 90% of the people who've tested positive have accessed treatment, and 90% of people who've accessed treatment have cleared the virus, and that's leaving a bunch of people behind at every step. And my fear is that when government and funding bodies' eyes are taken off Hep C, we're going to end up with this entrenched disease of disadvantage. We know who's going to be most at risk, and they're going to be people who are incarcerated regularly, and in Western Australia they're going to be largely Aboriginal people as well. They're going to be people who are disconnected from mainstream healthcare services. And so we need to know how to sustain this work going forwards, and we only need to look at the history of diseases like measles or polio in Western nations, and we can see that just because you think you've eliminated a disease doesn't mean the threat goes away. These things can come back quite easily. Yeah.
I think that's an important point too. And Paul, I'm just going to, because we're not going to get to everyone's questions here before we run out of time, there's a reference request for you in those questions there from Britt, who's asking about the name of the article that you quoted Peter from earlier. Can you go into the chat and just answer that question while we crack out another one here? Beck, I'm going to come back to you for this one, because we've got a question here from Rhiannon, who she says it's not so much a question, but I think it kind of is useful to respond to, and it goes to that broader social determinants theme that we're really getting to with some of our answers here. Not so much a question, but an observation. I am completing my Masters in Public Health and working on a research project on substance use and housing in Queensland. When I was researching uptake rates of DAAs, that's the direct-acting antivirals for Hep C, and healthcare access amongst individuals experiencing homelessness for an assessment and my research project, there was a huge gap in data and information for this cohort. Discuss, Beck.
Yeah, I think sometimes it comes down to, what we count says a lot about what we think matters. And I think one of the hardest things in my time working in this space has been getting government to do the work to actually collect the data to be able to move us from assumption and into acting on the basis of evidence. We rely a lot on researchers to kind of try and figure that out in the background, but actually the way that services are delivered sometimes is completely disjointed from, just picking up on Ellie's point about people being more than the siloed funding kind of stream that they're accessing at any particular moment in time. I think also the issue in housing is that often substance use is framed in terms of risk to tenancy, as opposed to the health and well-being of the person who uses drugs. And here in Queensland, we've just seen a return to this ridiculous notion of 3 strikes and you're out of housing, as though threatening people with eviction is an effective way to encourage
Thanks, Beck. We are at 2:30 and we've got a little bit of wiggle room here, but I am going to try and get everyone out semi on time. Juanita, your question around framing, we might put a pin in that one, but I would encourage you to go to AADC's website and just have a look at some of the framing of our recent submissions and advocacy documents on there, because that might give you a bit of a steer. John, I want to go to you just in terms of responding to the ideas that have come up in all of those questions before we close this out today. What are you thinking in terms of the conversation we've had so far around the Q&A session?
I'm off on a tangent. I think Paul's comment before made me think about a sort of population that we haven't talked about today. Can't talk about everyone all the time, but Aboriginal and Torres Strait Islander overrepresentation in the overdose toll is extraordinary. And interestingly enough, it's not a specific area of metrics in relation to closing the gap. And when we're talking about young people and injecting or whatever, you know, some of those people are Aboriginal. When we're talking about regional and rural and remote, like there's a whole lot of, there's another seminar for you to organise, Mel. I think it's a really big issue that needs to be unpacked, because people have, there's a lot of need that's not being addressed in any part of the service system, in the healthcare system, in relation to particularly Aboriginal people that are using drugs.
I think it's worth noting in that context, going back to the priority populations of the National Hepatitis and Drug Strategies, that Aboriginal and Torres Strait Islander people are priority populations across all of those strategies. And you're right, I don't think enough's being done. And part of that goes back to the point we made about the need for the re-establishment of the National Indigenous Drug and Alcohol Committee that gave some community control to the development and implementation of an Aboriginal and Torres Strait Islander specific sub-strategy under the National Drug Strategy as well. So I think those points are well made. We're going to need to close this off for today, because we're now at 2:33 p.m. and it's been a big conversation. I'd like to point everyone back to the chat if there are things that have come up today that you need a bit more support with, because we have to talk about some really hard topics today. I'd also just like to answer the question in the chat about whether this conversation will be made available going forward. The recording of this event will be up on the AADC website within the week, and I've also asked speakers to give me any links to their presentations or resources that they think might be helpful in the context of the discussion we've had today, and we'll pop those up with the link to the recording of the event on the website as well. So thank you everyone for hanging in with us today. Thank you in particular to the speakers who've come along today and shared your wisdom. I feel like we've got a bit of a brains trust going here today. It's been really good. And thank you to all of you in the audience who've given us over an hour and a half of your time today, when I know you all work really hard and are very busy and have a lot going on. So thank you so much to everyone. Happy World Hepatitis Day. I hope we've given you a few things to think about today, and we will all keep fighting the good fight as we look towards the development of the new National Drug Strategy in that context as well. Thanks everyone. Have a good afternoon.